Hello, welcome, and thank you for joining us for Hope for Parkinson's. My name is Lindsay Wetz, and I am the Director of Assisted Living at the Kensington Reston, a Kensington Senior Living community offering assisted living and 2 levels of memory care in Kensington, Virginia, in Reston, Virginia. Kensington Senior Living has 7 unique communities, 4 located in Virginia, Maryland, and New York, and 3 sister communities located in California. Kensington is truly privileged to support caregivers from coast to coast. Kensington Senior Living focuses on relationship-based care built on the foundation of our promise to love and care for your family as we do our own. That promise was what initially drew me to become part of the Kensington organization. It is programs such as the one you are attending now that are so important for those of us walking through a caregiving journey to hear from expert professionals on keeping us current with the latest advances in care, management, and treatment of conditions that affect seniors and their families. We are so delighted that you are taking the time to join us for this evening's presentation and hearing from experts from Inova. If you're new to the Zoom platform, this presentation is in webinar format. This means your cameras and microphones will remain off and muted throughout the presentation. We will be answering questions that were previously submitted at the time of registration, but we'll also answer additional questions submitted in the Q&A if time permits. Each of our attendees today will be receiving a recording of this webinar along with links to connect you with our distinguished presenters. Please share with friends and family. Kensington would also like to acknowledge our community partner, Steve Gurney with Pro Aging. Thank you. I now proudly introduce our first presenter, Dr. Faulkner. Please join us. Dr. Drew Faulkner is board certified in neurology and is a fellowship-trained movement disorder specialist. He is the director of the Inova Parkinson's and Movement Disorders Center and specializes in advanced care of patients with Parkinson's disease, essential tremor, and other movement disorders. He is uniquely qualified in the areas of deep brain stimulation, also known as DBS. Dr. Faulkner speaks nationally on various topics in movement disorders and is a respected national educator in Parkinson's disease and DBS. Dr. Faulkner serves as Associate Professor of Neurology at the UVA School of Medicine, Anova campus. He is a member of the International Parkinson and Movement Disorder Society, serves on the Telehealth Subcommittee of the American Academy of Neurology, and serves on the Medical Advisory Board for the Parkinson Foundation of the National Capital Area, also known as PFNCA. Thank you again for joining us. Have a great evening.
Thank you, Lindsay, and thank you to everyone who has joined us this evening to have a good conversation about the world of Parkinson's disease today. I am Drew Falconer, and that seemed like a very long introduction, but at the end of the day, I am a person who spends every day realizing that we as a community of patients, providers, and people living with people with Parkinson's, we all have the ability to strive a little harder and push a little stronger for better. Because there is better out there. And so that's what I hope to help with in this next hour. And we're going to bring on in a second 2 of my esteemed colleagues who will introduce themselves. But I just wanted to set the stage for what we hope to achieve tonight. So we are here to talk about Parkinson's disease. We're here to talk about a condition that affects 1 million people in the United States and is growing in numbers every single year. We are here to talk about a condition that really boils down to nothing more than a chemical deficiency in the brain. And we're here to talk about a condition that has experienced an explosion in therapeutics in a good way over the last 10 years. For those that don't know it, as of today in Parkinson's disease, we have 23 medications that we can use in some way to help with the daily struggle of Parkinson's. The challenge is the vast majority of patients, according to the Michael J. Fox Foundation, greater than 90% have not tried any medications that have been created in the last 50 years. Here's the challenge. Many people are stuck in the way we used to could, not realizing that we could do better. And so what we hope to do today through your questions is not to go through a presentation, not a click button, here's some slides and some data. We want to have a good conversation about the things you want to talk about with Parkinson's. And in doing so, I'm sure we will get to all those topics that we love speaking about modern, more updated therapies, and about having the courage to realize that sometimes good enough is not good enough. And also that courage to be your best self-advocate and talk to your doctor about your problems. And so before I bring on our panel, I do want to remind everybody at the bottom of your screen, there's a button for chat and there's a button for Q&A. We will be monitoring both. I'm going to watch them both. We have a number of questions that were submitted ahead of time, but as we go, please click on a button, either one, chat or Q&A, and send us some questions. We can talk about anything. That's the fun part about this. We are here to answer the things you want to hear about movement disorders and Parkinson's disease. Okay, you got us till 7 o'clock Eastern. Let's get Dr. Rogers and Dr. Irving on here, and we can give some formal introduction of the people who will help facilitate our conversation on these important topics. I'll let them both introduce themselves. I promise you they both have as lengthy of an introduction as I was graced with to begin with. But I can tell you personally that outside of all of our accolades, they are fantastic people. They are driven to help every person they care for every day. And we here at the Anova Health System in Northern Virginia really do take it personally that we want every person to do their best. Okay, I will pass it off to Dr. Irving first to introduce yourself, and then we can start answering some questions.
Thank you. Well, I certainly do not have as many titles behind my name as you do, or honors, but I'm Dr. Irving. I have been with Anova for 2 years. Prior to that, I was at UVA in Charlottesville, Virginia, doing my fellowship training in movement disorders. And then prior to that, I was in New York. But at heart, I'm still an Indiana Hoosier native. So I still have some good Midwestern blood in me. And this talk's really, I'm excited to be here today with Kensington. I'm a Restonian myself, love the city, love the area. And Kensington's just down the street from me. So I'm really excited to participate and hopefully answer some questions and have a good conversation.
I'm Dr. Sean Rogers. I actually came over with Dr. Falconer. I'm one of the co-founders of the Inova Parkinson's Disease and Movement Disorder Center. We came over from Georgetown where we did residency and fellowship. And I'm now also the director of the Memory Disorders Program, which I'm sure we'll talk a little bit about here, of the overlap of memory and Parkinson's disease. Very excited to be here. Lived in Northern Virginia now for 20 some odd years. And so this is certainly my home and my community, and I want to give back in any way that I can.
Fantastic. Welcome, everybody. I feel I'd be remiss, since we have a national audience, not to take a quick second and mention what we do at Anova Health System. We are a community-based system in Northern Virginia, and we have a pretty sizable movement disorder arm. I think we just hired, what, our 5th movement specialist? Isn't that right? So there's 5 of us that every day see patients and treat movement disorders and Parkinson's disease. We're a little different than some, where we tend to run clinic every day of the week. And with that, access and seeing patients is really our priority. And we see easily every week hundreds and hundreds of patients with Parkinson's disease. So if you're ever in the area, look us up. We are all available online. I'm sure, Sonia, you're on here. You can throw our website up on the chat for everybody to see. I know you'll get copies of that afterwards too. But we are very passionate about teaching. We're very passionate about moving the landscape of Parkinson's forward. And we're here to help if we can help in any way. Okay, let's jump into some questions. So how about we start with a softball, which is, someone asked, what is Parkinson's disease? How's that, Dr. Irving? You wanna give us the what is Parkinson's?
Well, I think you said it at the beginning. So at its root, it's a chemical imbalance. So in Parkinson's disease, there's neurons in the brain that secrete a chemical called dopamine, and those neurons have become diseased and die off. And so you get less dopamine in the brain. In the part of the brain that controls tremor, slowness, stiffness, and some kind of gait difficulty as well can develop. And that's really kind of the mainstay of Parkinson's, and how we make a diagnosis of Parkinson's is looking at those motor features. And that without those motor features, a diagnosis of Parkinson's isn't really able. Now, there's a whole bunch of other issues that can come up with Parkinson's that would take up the entire night, and then some if we were to dive into, so we won't go too crazy with that. But at its root, it's a dopamine problem. So we treat it with dopamine, and we treat it with different medicines that work on that system to try to keep you doing as well as you can for as long as you can and doing all the things you enjoy doing. Is that a quick 2-second blurb?
That was fantastic. Yeah, I'll just add that I tend to tell patients that Parkinson's is very much like your car driving down the street. The car is otherwise doing relatively well for having 70,000 miles on the odometer. It's just out of gas. And it being a chemical deficiency is very much like a tank of gas running dry. And our job is really medically to give you back that thing in which you're deficient in, dopamine, in as smooth and predictable of a way as we can to try to get that truck running again and keep it running as long as we can. Dr. Rogers, any addition to the world of what is Parkinson's or how you think about it?
Well, I think I'll add to it. People always ask, where does it come from? And I think a lot of people will say to me, I don't have any family members with Parkinson's. How did I get it? And I think that adds a lot of confusion to it. Most people, about 70%, don't have a family member with it. Only about 30% have any family history, really. And we've come to understand there's certainly genetic factors, but even things in our environment that can sometimes push us towards having Parkinson's disease. And we also understand that it progresses very slowly, and it starts, honestly, years, if not decades, before you realize it. So there's a lot of history and understanding of Parkinson's that as you talk to your doctor, as you discuss your symptoms, you'll come to find more about your own history, even from that conversation.
Answer. You keep going, though, because I'll add to that. Someone asked, what is the difference between a neurologist and a movement disorder specialist? Not to say we're not neurologists, of course.
So a neurologist, so we all started as neurologists. So neurologist is a field of medicine where you specialize in the nervous system. But as medicine is getting more advanced in every field, it's becoming more subspecialized. So in neurology, we're taught about everything from migraines to seizures to strokes to Parkinson's disease, Alzheimer's disease, you name it, anything that has to do with the nervous system. Difficulty with that is when you're focused on everything, it's hard to really become an expert and really feel like you understand the treatments, the process, the details of one condition as well as you need to. So if you choose to, like those of us here and the two others that aren't here with us tonight, you can choose to subspecialize purely in one condition. So we chose, after finishing our residency in neurology, to focus our time on movement disorders, which Parkinson's is definitely the most common that you see. So basically what that means is we spent an entire year to 2 years doing nothing but mostly Parkinson's disease. And frankly, since that's what we practice, we've made it our mission to understand as much as we can about Parkinson's disease, the disease itself, the symptoms, the treatments, the research, you name it. That's the biggest distinction between a movement disorder specialist and a neurologist, is that frankly, this is all we do. We don't necessarily, if we can help it, spend a lot of time talking about migraines or neuropathy. There are wonderful doctors within our practice that focus on that. And it's our goal is to do as much as we can specifically for movement disorders.
And would you both agree that every person with Parkinson's should try their darndest to have a movement disorder specialist be part of their team? What do you think?
Absolutely. Though recognizing, though, if you're in Northern Virginia, you can absolutely have a movement disorder specialist as your primary doc. I've trained in more remote areas where that might not be possible to see a movement doctor every visit due to travel burden or what have you. So the way, sometimes people will do is have a movement doc kind of weigh in once a year, take a good overview of how your treatment is. And have a local neurologist who's a good, well-trained general neurologist be able to kind of carry and alley-oop that forward. So it depends a little bit on geography, but I think if at all able, seeing a movement disorder specialist is just going to get you someone who's really, again, like Dr. Rogers said, honed in on that in all the different fields. 100 years ago, there wasn't as much need for that, right? Because all the medicines, there was one blood pressure medicine, there was one Parkinson's medicine. If there was any even of that, there's one seizure medicine. So it was really easy for a general doctor to keep track of all that. But now we have 23 in Parkinson's alone. It just gets too much, and that's why you really need a subspecialist.
Good answer. Yep. Okay, so it's still to you, Dr. Irving, on that point of diagnosis and what is this. We had a few questions about just the basic question of, so how do we diagnose Parkinson's disease? People tend to be a little puzzled by the diagnosis process. Is there a test for Parkinson's disease? And what to do if you don't think your diagnosis is accurate? That was asked.
Gotcha.
That was
So-
like 5 questions, sorry.
I'll try to hopefully remember all of them and get it all in a cohesive manner. So first, the diagnosis of Parkinson's. At its root, it's still a clinical diagnosis, which means it's made by a doctor, a movement disorder doctor, a general neurologist, sometimes a good primary care doctor, depending on your symptoms and the complexity. And what I mean by a clinical diagnosis is it's made by an exam. It does not require a blood test. It does not require any imaging. It's based on clinical exam. And the things we look for are those things that I was talking about earlier: tremor, slowness, stiffness. So classically, it's rest tremor. So when you're sitting and distracted, a little pill rolling tremor is the classic. And that's what everyone kind of classically thinks of as, oh, this is Parkinson's. But in actuality, the absolute necessary is something called bradykinesia, or slowness of movement. So that's often the doctor will have you kind of do something like this, or tap your fingers. And that's looking for slowness of movement. And it's not just slowness of movement, because with age, there's going to be some degree of slowness development, but it's really a special type of movement. It's movement that gets smaller and tighter as it goes. And that can manifest with movements getting slow and tight and harder to go. It can manifest with eyes, decreased blink, decreased arm swing, which is why often people can actually, and I know, especially as we do as movement disorders, where we see this all day, we can almost make a diagnosis as soon as we walk in the door, or have a very good sense that that might be what's going on just by the look on the face. And that's not because we're flippant about it. We still do an exam, but that's just because we see this all the time. So that's the bradykinesia. Have to have bradykinesia, and then you either have to have rest tremor or stiffness, and that's the rigidity in your arms or legs. There are some testing that can be done to confirm that if there's a question. One test is called the Dat Scan, which is a special brain scan that sort of uses a backwards way of measuring the dopamine neurons in the brain by tagging them on the backside. And then we get this colorful picture that can kind of say, is there a lack of those neurons in the brain? And that can sometimes be helpful in some in-between areas. The problem is it doesn't necessarily distinguish classic run-of-the-mill Parkinson's disease from some of these atypical Parkinsonisms that can sometimes be occurring. And that's where the clinical diagnosis and have good conversation and history is really most important. Was that all the questions? I think that was all the questions, maybe?
Yes.
Oh, what to do with,
yeah, what to do. Someone mentioned that they were puzzled by their diagnosis and what to do if the shoe, essentially if the shoe doesn't seem to fit.
Well, if the shoe doesn't seem to fit, there's always second opinions. If you haven't been seen by a movement specialist, seeing a movement specialist would probably be the first step, right? Because maybe the diagnosis isn't correct. Always educating yourself makes sense. Going on good websites. Don't just go to Dr. Google, where you're going to find everything under the sun, but go on good foundation, Michael J. Fox Foundation. Our website will have a lot of information, Parkinson's Foundation website, APDA, all of these foundations, and you might be able to kind of look through things and see if it seems to make a little more sense to you. But ask questions of your doctor. If you don't understand the diagnosis, it's well within your right to say, can you explain to me how you came to that diagnosis, right? And they should be able to have a clear conversation with you about what they see on your exam, and why that fits the best, and why maybe other things don't fit. So why is it Parkinson's disease and not vascular Parkinsonism or some atypical? Or say that, we may not be able to tell right now, but this is what my best suspicion is, and this is what I want to treat you for, because this is how we got to get you feeling better.
Awesome. Good answer. Yeah, I just wanted to add some data to that. Remember, folks, diagnoses can change. Diagnoses aren't in stone. And we see people all the time who are told 5-6 years before they have Parkinson's, and in reality, they don't. People are making their best guess of what's going on based on the symptoms and medication response. But at the end of the day, we're taking symptoms that are bugging you and having to make a logical deduction as to the cause. But there can be many causes that lead to symptoms, and sometimes it's not as easy as black and white. There's a study in the Neurology Journal in 2014 that looked at patients who were diagnosed with Parkinson's disease and followed them naturally to autopsy. And we found out that even as a movement trained specialist like us, we tend to be wrong about 15% of the time. That number just gets worse as you go away from the specialty movement disorder position. So the whole point to that, to answer that question a little differently, would be just if it doesn't seem to fit, keep asking, because sometimes it doesn't fit because it doesn't fit. Dr. Rogers, Dr. Irving brought this up and people had asked about it. Can you explain the difference between Parkinson's disease and Parkinsonisms?
Right. So
Besides just that it's a cop-out.
Parkinsonism is our fancy way of saying it looks like Parkinson's disease, but we're not sure. So that can mean a couple of things. So Parkinsonism can simply be, frankly, going back to the misdiagnosis, someone that has tremor, maybe is moving a little slowly, but maybe they have overlapping symptoms. So someone might have tremor because they have essential tremor, and maybe they're not walking well because they have back problems, scoliosis, knee problems, neuropathy, etc. And as we get older, those symptoms get worsened. So sometimes they're described as looking like they have Parkinson's, and that's really a type of Parkinsonism. Now, in terms of actual diagnoses, there's a term called vascular Parkinsonism, where basically you get either small strokes or damage to the brain from vascular disease in some of the same areas that are affected by Parkinson's disease. And for one reason or another, just the way it happens, that tends to affect the legs more than the arms. So someone might not have arm symptoms. That's why often when we're making the diagnosis, unless it's fairly clear cut, if we're not sure, we'll get an MRI of the brain to see if there are strokes or vascular disease that could have caused damage to the brain to cause Parkinson's-like symptoms. Some psychiatric drugs that block dopamine can cause a medication-induced or medication-caused Parkinsonism. And then there's some other diseases that are, let's say, cousins of Parkinson's disease, kind of atypical Parkinsonisms that can cause Parkinson's-like symptoms. But probably the single most important thing about all of the other Parkinsonisms that are not Parkinson's disease don't particularly benefit well from the medicines. So if you give someone levodopa that has a vascular Parkinsonism, or frankly just has Parkinson's-like symptoms from back problems or tremors, the medicines will not help them. So it's incredibly important to differentiate what is a Parkinsonism or something that looks like Parkinson's disease from actual Parkinson's disease, where there's a dopamine deficiency that's treatable. As Dr. Irving mentioned, a Dat Scan is one option, or simply put, sometimes we will start a medicine and see if patients get benefit, because that will tell us a lot about their level of dopamine.
Good answer. Thank you, friend. And since you're the director of memory, why don't we parlay that into what is the link of Parkinson's, of course, to dementia?
Okay. So the first thing I have to say is a terminology thing, because this comes up a lot. When you hear the term Lewy body, if you've done any Googling about memory and Parkinson's, you'll come across the term Lewy body dementia. So a Lewy body is simply a buildup of a protein in the cells of the brain. This protein is called alpha-synuclein, and it's thought that it's doing damage to the brain cells, and that's what's killing these dopamine cells in Parkinson's. So really, how someone has memory problems is when those cells, those Lewy bodies, start to spread away from the movement part of the brain, the dopamine part of the brain. So someone with Lewy body disease will get those Lewy bodies, that protein buildup throughout the brain very widely. That's why it's also called diffuse Lewy body disease. It's spread diffusely. But even Parkinson's disease, in some patients, those little buildups of protein will start with the dopamine system and expand outwards, and then you'll start getting other symptoms, including very nearby is some of the pathways for memory. And if you start having damage to that system, you'll start to see memory problems in Parkinson's disease. It can start very mildly. A lot of Parkinson's patients, probably 60 to 70%, will have some mild memory issues, short-term attention, maybe a little bit of trouble mentally planning things as well, or with mathematics or word finding. A smaller group can go on to actually have some bigger memory and reasoning problems. And then a portion of Parkinson's patients can go on to actually have a full dementia. At that point, it takes longer to get there for Parkinson's disease, but a Parkinson's disease patient can look almost exactly the same as a Lewy body patient. It's just how long it took to get there and how long it took the brain to be affected by the spread of these alpha-synuclein and Lewy bodies.
But can you have Lewy body dementia without Parkinson's disease?
You can. It's a separate diagnosis. It's often used interchangeably, sometimes even by doctors, so it can be confusing. Officially, Lewy body disease is the onset of Parkinson's symptoms within 1 year of the onset of significant memory problems and dementia. So it's really the timing that matters. We understand under the surface that it's because that damage is occurring to the brain in a more rapid, widespread fashion. So Lewy body disease tends to happen quicker. Whereas someone with Parkinson's disease, they might have stiffness, slowness of movement, tremor, mildly coming on for literally decades, 30 years, 40 years even in some cases, and then they can start to have memory problems. But usually, if someone has Lewy body disease, it's very early within the first year. So that's probably the biggest distinction. They can eventually be very similar, but really Parkinson's disease typically takes much longer to get to where they have memory problems, if at all, because not every Parkinson's patient has memory problems.
Thank you. Okay, to that point about progression and timing, and by the way, if Chris is on our director, if you could activate screen share for me, I'd love to be able to use the whiteboard, because a lot of people have asked questions about new Parkinson's drugs, and it would actually just make sense to just list them all so people can take a screenshot, and then you can read about them. But while Chris is doing that, back to you, Dr. Irving. We had a number of questions about progression, about timeline, about if someone had asked, they're 4 years in, is there any way to predict where it's going from there? And someone else asked about why does Parkinson's progress at different rates, and what does that mean for me?
So real easy one on the back end there. So everyone with Parkinson's progresses at a different rate, and that's highly individualized. And there's still a lot unknown about why that is. I mean, some of it can be due to just general medical conditions, right? And general brain health, vascular disease, like Dr. Rogers was talking, vascular Parkinsonism. Well, nothing operates in a vacuum. So the brain doesn't operate in a vacuum. So if you have other medical issues, other risk factors to your brain, that may change, the progression of it. Though there's not strong evidence to say that it's X, Y, or Z, or that's kind of what's going on. The best way to kind of slow progression is exercise. And that's what really has the most evidence to slow progression is exercise, exercise, exercise. And so that's what I hammer home with my patients, because that's really what's the most reversible. Ultimately, the disease is going to be the disease, despite what we do as far as medicines. The best thing we do with the medicines is get you doing well so that you can continue exercising, keep your brain active, keep your brain healthy, and keep doing all of those things, because that's really what kind of seems to indicate that you're going to do the best the longest. And so that's kind of my approach as far as medications go. The rate of progression, like I said, is highly individualized. One way I kind of counsel my patients to think about it is to think back over the rate of progression you've seen in yourself so far, and that seems to be the trajectory that you're on. Though there can be a threshold effect where you don't notice symptoms and then you do, and then there's you won't notice tremor until suddenly you have tremor, and then suddenly there's that kind of breakdown. You've lost just enough neurons where now maybe you're noticing more rigidity or you're noticing more slowness. And it's not necessarily that the disease is increasing in how fast it's progressing. It's just that you're noticing more of these symptoms because there's less reserve in your brain. So, for the person who asked about 4 years, so, think about where you were 4 years ago, where you are now. And, if we could draw a trajectory, that's probably kind of where you're at. But the rule is slow progression. Dr. Rogers was saying decades even. So it really kind of depends on your age of onset and kind of your activity level and things like that. I tend to think of things as early, middle, and late. In those buckets of kind of early disease, people are doing really well. You may not even know you have Parkinson's, or other people don't know you have Parkinson's. You're really going along really well. Middle, you're aware you have Parkinson's. Other people may start to notice the medicines maybe are fluctuating a little bit. And then more advanced, where we're having a lot more difficulty with medicines kind of fluctuating. To keep your symptoms under control, it's clear you're having Parkinson's. Maybe you're altering some of your daily activities. And each of those kind of buckets can last for a variable amount of time. I say, 5 to 10 years is kind of what I tend to say. And each of those buckets, sometimes shorter, sometimes longer. It's highly variable. Do either of
Thank
you
you, Dr.
guys
Irving.
have a more specific answer you give your patients?
Well, I just say it's slow. It takes 10 to 20 years to reach the point where that dopamine deficiency reaches a point where motor symptoms come out. Classically, if it's just a chemical problem, because that's all Parkinson's is, when that dopamine level is dropping to 20% down, that's when we start to lose our sense of smell. 40% down, talk and sleep, act out dreams, 50% down, bad constipation. It takes that dopamine level naturally being down by about 60% to get the movement symptoms of Parkinson's that usually leads to a diagnosis. So if it took you 10 to 20 years to drop to 60% down, then it should take you another 10 to 20 years to really progress like to an extreme degree. And if our average age of onset is 65, then 10 to 20 years is okay, right? The challenge is we really need to treat people the best that we can for today. Yes, I know it's hard not to think about a year from now. It's hard not to think about a week from now, but the future is not guaranteed. We really don't know what's going to happen. We need to cross bridges when they come. We need to use the best tools today and plan for the future, but not really leave things on the table thinking we're going to save stuff for down the line. We need to get you the best we can today. And that's where the new medicines come in. And so what I'm going to do, let's try this, and I'm going to have everybody else chime in too. I'm going to switch to a whiteboard. Let's see, pink is not a fun color. Okay, I feel pink's a great color. Can everybody see a red smiley face, by the way?
Yes.
We got it? Okay. So we had innumerable questions about new medicines. And so what I want to do is lay out over the next 5 minutes all of the new therapies that we have for Parkinson's, if for no other reason to give people homework on what to read about, because in terms of medicines that have been created in the last 50 years, only about 7 to 10% of Parkinson's patients will ever try one, okay? And to do that, I want to start way back with the gold standard of treatment. Let's see, I can make this a little bit bigger, maybe. Can you see levodopa on the screen, team?
Yes, but you might want to make it black, so it's black. And a little more visual for patients, for people.
Thank you, friend. Yeah, I can't figure out how to make the size big. Oh, here we go. I can make the font bigger. See, this is where you would think by now we'd be good at Zoom, but you know, so it goes. Levodopa. There we go. Gold standard therapy was actually created in 1956 for those that don't realize. Prior to 1956, there was no levodopa. And like Dr. Irving mentioned, the journey of someone with Parkinson's was challenging. The average life expectancy was about 6 to 7 years. There wasn't a good therapy and it was rough. And then in the 1956, we came up with this idea of giving patients this chemical, which if you didn't know it, levodopa goes into the brain and the brain takes off the levo group and look what's left. Dopa. Levodopa is dopamine. You have to think about it as dopamine. You have to think about it as this is the thing giving my brain back the thing I need. So all of a sudden in the early 1960s, we had the ability to really kind of fix the fundamental problem with Parkinson's. The problem was levodopa by itself had to be given through an IV, and it had to be given every 2 to 3 hours at a high dose. In the original studies, we gave people 1 to 1.5 grams of levodopa through an IV every 3 hours or so. And guess what? People got better, but they all profusely, for the most part, got sick and vomited in the process. So all of a sudden this was 1950s, so early 1960s, we realized that we couldn't give levodopa by itself. So that's when we created what we all use today, which is carbidopa levodopa. For those that don't know it, you cannot get levodopa by itself. Everything you have is carbidopa plus levodopa, because carbidopa does a couple of things. It allows you to take levodopa without having side effects. And it also allows us to give 100 milligrams instead of 1 gram to 1.5 grams. That's why the old trade name was Sinemet. It was supposed to be Latin for sin emesis, or don't vomit, because when you added carbidopa to levodopa, people stopped puking. So for 50 years, the gold standard has and is carbidopa levodopa as a foundational therapy to treat Parkinson's. The reason why is a good one. It's like giving a type 1 diabetic insulin. It's like giving a Parkinson's patient who's deficient in dopamine. The challenge with carbidopa levodopa is not that it's not a fantastic chemical. It's that it is not very consistent in how it's delivered. So see, you're going to be great at Nerve Quiz Bowl after this. The half-life, or how long it takes for original carbidopa-levodopa to break in half, is only 2 hours, meaning it lasts in the best case scenario for about 3 to 4 hours in a very up and down fashion. Well, that's a challenge if we're trying to fix a chemical problem all the time. So most patients over time tend to fluctuate. They tend to feel their medicine kick in and go away, kick in and go away. And those fluctuations during the day usually mirror the medicine coming in and going out and coming in and going out. We've known this for a long time, so we've created a whole host of different categories of medicines and newer therapies that have tried to help with the very short duration of action of the foundational medicine that most people use. Now I'm going to list out the categories and then list out the drugs. And in doing so, I'll mention each category, and then I'll ask our team to talk about what each one does. How about that? Instead of me just gabbing away here. Okay, so let's start with the MAO system, specifically the MAO B channel. Dr. Rogers, while I list the drugs in this category, will you talk about what Mao B inhibitors do?
Sure. When we think about the dopamine in the brain, there's two sides of it. There's the how we get more dopamine back into the system, how we replace that dopamine deficiency. And then the other side of it is how can we keep it around longer? And a big difficult part of that is understanding that in the body, there are certain enzymes that take away dopamine, that break down dopamine on purpose, because we're not supposed to necessarily have just all this dopamine floating around our system. And the body doesn't know that you're necessarily deficient, so these enzymes are still there. They can be located in the body, or they can be located in the brain. So the MAO, or the monoamine oxidase enzyme, is an enzyme that gets rid of, that gets rid of dopamine. So those medicines that Dr. Falconer typed and then accidentally erased.
I deleted it. I hit the wrong button. Sorry. Keep going.
They are medicines that block the MAO enzyme, the monoamine oxidase enzyme, and the MAO-B specifically in the brain. And the idea is when you either are making dopamine naturally or take an artificial dopamine like levodopa, these medicines help to block the breakdown to keep it around longer. So they can be given by themselves to help promote your natural dopamine if your symptoms are mild and you still have plenty of dopamine around, or they can be given with a medicine like carbidopa-levodopa to help boost that levodopa to keep it around longer. I know I saw in one of the questions someone asked that if you're having a bad reaction to Sagittaline, what do you do? And the answer is there are other options. There's two other options within this one. These are in order of when they really came out. Sagittaline's the oldest. We don't tend to use that too much. Sagittaline is the next, and then Xadago is probably the most recent. And then, as we'll discuss, if those don't work, if you have a reaction, you just don't tolerate those well, then we try something different.
Like possibly a dopamine agonist. Dr. Irving, can you tell us what a dopamine agonist is and the role of those in care?
Oh, I'll talk while you're typing. That's right. So dopamine agonists. So when I'm in the clinic, I usually use my fist. So I use my fist as levodopa, broken down to dopamine. It's your strongest and best medicine because it's straight up dopamine. But dopamine agonists, like the name suggests, so agonist is opposite of antagonist. So it's encouraging dopamine. It works on the receptor side. So dopamine in the brain, the neurochemical floats out of the presynaptic neuron, goes to the postsynaptic neuron to send a signal. And that's how electricity is transmitted in the brain. So dopamine agonists work on the receptor. So they mimic the effect of dopamine. They pretend like they're dopamine in the brain and get on the receptor and activate those signals to get sent. And so these are, Dr. Faulkner wrote up all the different names for them. They all work very similarly. There's some kind of pluses and minuses to each. Their kind of formulation and ultimately often how your insurance will cover each one individually. They're really nice because they come in a once a day or a 3 times a day formulation. Again, some of that boils down to insurance and getting that through, but they work really well to mimic the effect of dopamine with less of that pulsatility. And second to levodopa, these are our strongest medicines because they're working, again, right there directly in that kind of electrical signal pathway, whereas some of the other ones are more on the periphery, also working in good adjunct.
Cool. Yeah, and I'll add that Nupro is unique because it's a patch. It's the only medicine we have that's transdermal. You wear a patch 24 hours a day. It bypasses the gut and just delivers therapy. So I like Lupro. Okay, back to you, Dr. Rogers, to the COMT inhibitors.
So same theme. The COMT or comethyltransferase inhibitors are medicines that block the breakdown, again, of dopamine through a different mechanism. In this case, not in the brain, in the body. And as I mentioned before, these enzymes are everywhere. These particular medicines keep the enzyme from breaking down the dopamine when you take it before it ever gets to the brain. That's allowing more of your levodopa to get to the brain. The two main ones are entacapone, which is short acting. You take it with each dose of levodopa to help that levodopa to get to your brain in a higher quantity. And then the opicapone is a once daily form, again, that you can take once in the day, and it allows your levodopa, more of it, to get to the brain because it's not being taken away by this COMT enzyme.
Great answer. I love it. Dr. Irving, would you like to tackle amantadine? Because we have two amantadine drugs. Not that we know how they work.
Action? Okay, I was going to say.
Yeah. What,
the mechanism of
NMDA, maybe? I mean, we don't know.
who knows a lot of different things. So amantadine is actually, if I remember correctly, older than levodopa. So it's originally an antiviral medicine. So go figure there. But it works really well I use it a lot for dyskinesias, or those extra movements that sometimes can be used. No one really understands why amantadine works in any of its formulation, but it does. And so we use it. So amantadine IR is, again, a short acting medicine, multiple times a day, but works really well. It's been around the longest, so it's by default, therefore, the cheapest and oldest and kind of easiest to get from a actual standpoint. But Osmolex and GoCovery are also amantadine, but in newer formulations that are once a day. So they provide, again, more smoother control of symptoms. Osmolex is old amantadine covered in not one, but two layers to slow the release and more control release of the amantadine throughout the full day. GoCovery is, again, once a day at bedtime, longer acting, a little bit different than the Osmolex. That one, is it beads? It's not beads. It's just a completely different kind of mechanism for how it absorbs. But it can be helpful for both wearing off as well as those dyskinesias. So that's some of the benefit of the GoCovery and why I use that one maybe over the classic amantadine. But yeah, they're excellent add-on therapies as well.
Well, and the trick to GoCovery is that based on how it's formulated, it allows the amantadine level to be tolerated at a level that actually helps Parkinson's too. So it kind of works like a dopamine agonist, and it's once a day, and it works well. And it's actually FDA indicated both for dyskinesia, which is a symptom of too much, and off time, which is a symptom of not enough. And that's a good time to remind folks, don't forget dyskinesia, that thing that every patient is scared of, that wiggling movement that we all worry about. That's really a side effect of too much medicine, right? That's when you're hitting the peak of the roller coaster, and off time is when you don't have enough dopamine in your system and symptoms come out. And that can be hard for folks because we have to balance periods of too much as well as periods of not enough. So smoother, more predictable, more consistent is what we aim for. Okay, we have two more categories that we're going to run through quickly. The 1, 2, 3, 4, the fifth one is the adenosine category, which I will quickly say is a non-dopamine way to treat Parkinson's disease. We have one medicine, Istradef. Now, don't quote me on the spelling of this. It's called Norians. I tried. But it actually doesn't work on dopamine directly. All these other categories try to fix dopamine. Istradefylline works differently through a different pathway in the brain to try to free up movement. The real selling point of it is that it tends to be very well tolerated, and it has a half-life of how long it lasts in the system of about 80 plus hours, while, let's say, carbidopa-levodopa is 2 hours. Entacapone has a half-life of only 45 minutes. So we're adding Norians to things to try to give some consistency in a non-dopamine way. And then Dr. Rogers, back to you for the final category, which we will call as-needed therapies. Okay? Now, what is an as-needed therapy, and what is this craziness that I'm talking about?
So an as-needed therapy is the way it sounds. It's when you need something more. There are certain medicines that you can take as, let's say, a boost or an additional medicine to your schedule. So a good example would be if someone's taking carbidopa-levodopa, either the Sinemet form or Rytari, and they feel like at certain times of the day that it's wearing off or simply not enough. Some people might say that when they first get up in the morning, they feel tired, they feel like it's hard to move, or they're very stiff. We all feel a little bit that way, but in some cases, it's that they haven't had medicine in 10 hours. Or other patients might feel that between their doses, they get very stiff and can have a hard time moving. Or we have a few patients that will need to go out and, play pickleball. And before their game is scheduled, they will have a hard time moving, so they can use an as needed therapy. And there are 3 options. The goal of these medicines are quick acting and don't last that long. They're not to replace your other medicines. They're to supplement your other medicines. So one type is Apokyn. It's an injection of apomorphine. You literally, like it sounds, if you feel like you're wearing off, you're not moving well, and you're not due for your next dose of levodopa, you give an injection. It kicks in about 10-15 minutes, and it helps you move better. More recently was a medicine called Inbrija, which is still actually levodopa. It's an inhaler. You can actually take 2 puffs of the inhaler, 2 different little capsules, and it gives you the equivalent of about a half tablet of levodopa. But again, because you breathe it in, it absorbs quicker. It absorbs again in probably 15 to 20 minutes. And last but not least, the most recent is called Kenmobi. It's apomorphine, which is a type of dopamine agonist, looking back to our list, that it's actually a little strip you put under your tongue. It's like those little Listerine strips for bad breath, except for there's no flavor to it, really. You just put it under your tongue, it absorbs in quickly, and it gives you a very quick boost of dopamine agonist. Again, this one probably kicks in about 5 to 10 minutes, and all these are very effective, and it's very small. You can just put it under your tongue, and hopefully you're good to go for whatever activities you have coming up.
Yeah, this category came about because we are very good at teaching our patients to stick to the plan and stick to the interval and stick to the regimen, right? But what do you do if it doesn't hold and you have off time, or you're somebody who goes to exercise and humbles out because you deplete your dopamine quickly, or you're worried about going to dinner with your friends because you're worried about getting up and coming out? Well, these as needed therapies are indicated up to 5 times, all of them, 5 times a day or not at all. You get to choose when you take them to fill the potholes when they occur. It's a very liberating thing, and we like to write them because it gives people their confidence to go out again. Okay, we are closing in on the end of our giant list here, but I'd be remiss if I didn't add to the carbidopa-levodopa category, because if you look at it, here's this giant list of medicines that try to augment what carbidopa-levodopa is trying to do, seeing that classic carbidopa-levodopa, classic Sinemet, that chalky little yellow tablet that you all bought yesterday from the CVS is the exact same chalky little yellow tablet that was released commercially in 1972, 50 years ago. I think that's a half diamond jubilee per the Queen's latest, my understanding of royal lineage. But we have actually tried over the past 50 years to do better with carbidopa-levodopa itself. In 1992, let's see if I can type, we came out with carbidopa-levodopa CR, which many people will see out there. It's generic. It's either CR or ER. It's a little tablet. It's usually football looking. Usually it's a little lavender color. All they did to try to make carbidopa-levodopa, the original medicine, last longer is they ground it up into a powder and put it into a wax tablet. And that's what Sinemet CR, or carbidopa-levodopa CR, is just original Sinemet in a tablet of wax, such that when the body eats at the wax, it leaches out medicine differently. It tends to give people, instead of about 4 hours, about 4 hours, and on average, 4 hours and 20 minutes of good on time. And then in 2015, we came out with a medication called Rytary, which is carbidopa-levodopa, but instead of being a tablet, it's a little capsule with about 150 little beads that all release carbidopa-levodopa at different times. And so that was the more kind of modern way to try to get levodopa to last longer in people's systems. And so we kind of went from original Sinemet lasting 3 to 4 hours, Sinemet CR to getting us closer to 3 to 4 hours and 20 minutes, and then Rytary giving on average about 1 to 1.5 more hours of on time per dose. So again, foundational medication on the left. We need to fix the foundation first to smooth things out. And then we add to it augmenting medicines from the right that can extend and smooth out the foundational therapies. That's what we do 100 times in clinic, guys. You are now in on our secret. All we're trying to do is realize that if you have a chemical problem, During the day and night, the tank is either full and you're good, it's underfilled at that moment and you have symptoms, or we're overfilling it and giving you side effects like dyskinesia. Okay, so this is good reading material for everybody. Sean and Hannah, did I miss any? It's pretty long list.
I don't think so. Then we got them all.
Okay, touchdown. That answered like 15 questions. We're running out of time, but I hope this was helpful. They had a lot of folks who asked about focus ultrasound and DBS. So Sean, if you want to answer who's a candidate for focus ultrasound or for DBS, we'll start with DBS.
Okay.
And then we can do a quick blurb on focus ultrasound too.
Okay. So first and foremost, all of these areas we're talking about, as mentioned way back when Dr. Irving was discussing what is Parkinson's disease. It's all about the pathway in the brain that controls movement. It's called the basal ganglia. And we know that when we add dopamine, replace that dopamine deficiency, it allows that circuit to function better. So another way of augmenting that circuit is electrically. You can put a stimulator into the brain, into a different part of that circuit, and you can actually adjust that circuit through programming. It's very small. It's about the size of the tip of a pen, and it's passed in very safely using very advanced mapping, and it's put in a different part of the basal ganglia. Now, the reason I say this is it's the same pathway as dopamine. So first and foremost, the most important thing is benefit from dopamine. If someone gets good benefit from dopamine, even if it doesn't last that long, we can say they will probably get similar benefit as their best on time. So if you take carbidopa-levodopa and you only feel great for an hour, well, that feeling you feel when you feel great for an hour, you can get from the stimulator in that same circuit 24 hours a day. So number one, patients need to get benefit from levodopa to some degree, because we can point to them and say, okay, this is what you can also get from DBS. Now, beyond that, it's having symptoms for at least 4 years. The other advantage of having, obviously, benefit from dopamine is helps us confirm that it is, in fact, Parkinson's disease and not Parkinsonism, because a DBS would not work as well in Parkinsonism, because, again, their problem isn't necessarily with that circuit. And then we would generally, I think the guidelines is to have starting to have fluctuations. So if someone's taking levodopa 3 times a day and it's perfect, no wearing off, no problems, okay, they probably don't need to have the DBS surgery yet. But if you're 4 hours since symptoms, you get good benefit from levodopa, and you're starting to have fluctuations and wearing off, then that makes you a good candidate. Often what we will do is we'll have the patients come in without taking their medicine, take it in front of us so we can see specifically what the medicine does and say, okay, here are the symptoms the medicine makes better. So these are the symptoms that the DBS would make better. And more importantly, we can say, but here are the symptoms that are not necessarily made better by medicine. You know, again, if someone has a knee problem and they're not walking well because they have a limp, DBS won't make that better because dopamine doesn't make that better. The only patients that really shouldn't have a DBS are patients that aren't healthy enough for surgery. You know, if they have significant heart issues, lung issues, other health things. So we would ask them to, you know, be evaluated by their primary care physician, other doctors if needed. From a neurologic perspective, the patients that aren't good candidates would be someone with dementia or significant cognitive impairment. Having a DBS does not cause someone to have dementia. It doesn't do that harm to the brain. But if someone already has dementia, it is a very difficult process for someone with dementia to get DBS. So it can, in many ways, exacerbate their dementia if they already have it. So really, it's 4 years since symptom onset, benefit from dopamine, wearing off or fluctuations of medicine, so that we need to look for something to kind of make it more consistent. No evidence of dementia. And the last one I'll throw in, no evidence of significant depression or anxiety, because again, that can take a bit of a toll with the surgery process. There you go.
Awesome. Yeah, I tend to boil it down to my patients that we are dealing with truly just a chemical problem with Parkinson's, but that chemical problem becomes an electrical problem that then turns into symptoms. And we are spending that giant list of things. I mean, it's 23 medicines trying to get that chemical back into the brain through taking medicine that has to push its way through the bloodstream and push its way into the brain. But DBS lets us skip that and go straight to the electrical problem to try to shut it off. And so whether we are trying to get the medicines the best we can or using DBS and medicines, at the end of the day, we're fixing the symptoms. And that tends to work for me, and that's why we tend to do it a lot. It's a great therapy. It really does change lives. And people had asked about focused ultrasound. Well, focused ultrasound is something that's new as of the last 5 or 6 years here in the US. And instead of putting a device into the brain to affect the electrical problem, it uses about 1,000 different ultrasound beams that all focus on that circuit. They all coalesce the sound waves and they create heat, and it creates a lesion in the electrical pathway to try to block that pathway to fix the symptoms. So in the world of Parkinson's, it's all about getting the medicines right to fix the chemical issue. And if that's not cutting it, talk about some piece of technology to address the electrical problem that comes from the chemical issue, with the idea that all of that will stabilize your symptoms. Dr. Irving, any thoughts on focused ultrasound? Because a lot of people hear about it. Or anything you'd want to add?
Yeah, a couple things. I did want to just circle back to great overview of the DBS. One caveat would be tremor. And response to dopamine is super important for planning for DBS, except for tremor. Tremor is one kind of anomaly that sometimes doesn't even respond to medicines at all in Parkinson's, or sometimes doesn't respond enough, but will respond to DBS. So tremor is kind of one that we have to put a little asterisk next to. And in fact, that 4-year rule can sometimes, of having disease, if you have a really severe tremor that's not responding to medicine, sometimes DBS will be done even earlier because it works really, really well for tremor. So I just wanted to put that plug in case someone's wondering about that. Focused ultrasound, I think that was great. I usually pitch it to my patients as it's a new way of doing an old procedure. The old way was they dropped a wire down into the brain, they heated up that wire and they burned a hole in the brain. Now they use ultrasound waves to do that without having to put a wire in there, but they still ultimately are burning a hole in the brain to alter the circuitry and alter the electrical signals to control those symptoms. The other thing, focused ultrasound is only approved actually for tremor. And it's not approved for slowness and stiffness in Parkinson's because the target of the brain's a little bit different. And so if slowness and stiffness are a problem, which if you have Parkinson's disease, they are, or they will be, then that might not be the best choice for you because you're burning a hole in the part of the brain that's not going to help those symptoms.
Reasonable. And it's still unilateral. So as of today, you can't do focused ultrasound on both sides of the body. Parkinson's is a bilateral condition. That's why we're a little hesitant sometimes to do focused ultrasound. Okay, great questions, great answers. Kensington folks, we are approaching 7 o'clock. I wanted to add one more answer to a question, and then we can kick it back to you guys because there were some questions about Kensington itself. But the question I want to end with is somebody had asked about when, as the family and the patient, should you, how do they put it, ask for an increase in medicine to get even more improvement either now or in the future. I boil it down to, when do you speak up? And I want everybody who has joined this call to realize that we don't want you to be the good patient. We don't want you to show up to clinic and just say everything is great. I mean, we want that if it's the truth, of course. But we want to know what your day-to-day is like. We want to know the things that are holding you back, and your doctors want to know that too. So to answer that question, what I'll do is just tell everybody to please realize that the difference between doing okay with this and the difference between that and really doing well and thriving with Parkinson's is really having the courage to be your best self-advocate, to step up and to talk to your doctor about the things that you can't do or the things that you wish you could do with Parkinson's disease. I can't tell you how many people that I want to lean over and give them a hug when they walk in, and I say, how are you doing? And they say, I'm good, but I can't do this, I can't do that, right? Instead of pulling teeth to try to figure out what to do next, take the initiative, lead the conversation with the things that are holding you back every day. Because I hope you've learned from this that we have tools available today, FDA approved and available tools, which have been designed to try to make the quality of life in the daily journey of someone with Parkinson's better. But if you're only taking one thing and you've never tried anything else, and you are stopping doing things because of this, that's that moment when you need to have the courage to be an advocate and talk to your doctor about what's bothering you. And honestly, if they tell you, oh, you're on levodopa, that's the best thing we got, don't worry about any of this new stuff, a second opinion is never, never a bad thing. Because it's not about them, it is about you, and it's about you getting better and living your best day to day with this thing called Parkinson's. And I promise you, we make it real every day. That's the fun part. Any closing thoughts, Dr. Rogers? And then we'll pass it back to the Kensington folks, sir.
No, I think my main closing thought would be just to sum up and say, it doesn't have to be us, but if you have access and you can find a movement disorder specialist, especially these days where, you know, there is a lot more accessibility through video visits, check in with a movement disorder specialist just to make sure you're on the right page, make sure you're going in the right direction. If there's something that's not working for you, again, it doesn't have to be us. Find someone that can really listen to you and look specifically at the concerns you're having, the problems you're having, and, you know, find that part of your team that maybe is missing.
Great. Dr. Irving, final word, anything for our team out there?
No, I think I just echo what you guys said. You guys said it all, and hopefully this was a good conversation. I don't want to keep anyone longer, but very glad to be here. Hopefully this was helpful. This was fun, and we're happy to do it.
Thank you, everybody. We're the Anova Parkinson's and Movement Disorder Center. You can find us online at www.ipmdc.org, Anova Parkinson's and Movement Disorder Center, ipmdc.org. We've got all kinds of resources, all kinds of things up there for you. But we are so grateful for the Kensington team for allowing us to partner on this. And we hope that you got some things out of today. If nothing more, we hope you leave today's talk with a big old ounce of hope. Because life is beautiful. It's amazing. Every day is a gift. And if you aren't there yet, you need to have the courage to step up and ask for better, because it's worth it. I promise. Okay, Kensington team, wherever you are, back to you. We have some questions about what you offer.
Hello. Okay.
Hi, Lindsay.
Hi. Thank you for that. So yes, there are some specific questions toward the Kensington and what we have to offer. So I'm just going to go through those pretty quickly. So the first question is, what programs are available in Kensington's facilities for those with Parkinson's? So the Kensington offers a variety of programs for current residents and outside guests. So to name a few, the Kensington Reston offers Virtual Communications Club in partnership with PFNCA, and that is every Tuesday. Every Thursday, we offer on-site exercise class, again, with partnership with PFNCA. The on-site exercise class, I can speak from experience, a lot of our residents on-site really enjoy the class and benefit from it. And then we also have residents, or not residents, but potential residents and outside guests that come and also join the class. We also offer big programming with on-site rehab and then a monthly Parkinson's support group. So the support group is a great way for residents to just get together, and it's a way for them to feel like they're not alone because they all can relate to each other somehow. So if you're interested in hearing more about any of these programs, please feel free to reach out to us for more details. The next question is, do you have rooms for physically challenged individuals to try out for a stay for 7 days? So any respite inquiries can be answered by calling our community. Our number is 571-494-8100, and by responding to the email that you will be receiving from the Kensington, so we can walk through what your specific needs are, and what kind of respite stay you're looking for, because it does vary. And then lastly, how do you handle medication management for Parkinson's at the Kensington, as specific times for meds are essential? So medications are definitely essential regardless. So we do have a nurse on site 24/7. There is always a nurse in the building. And also the staffing ratio for the three neighborhoods. So for assisted living, for every one care partner, they oversee 8 residents. For connections, we have a 1-to-7 ratio, and our Haven neighborhood is 1-to-5. So these ratios include strictly care partners, so the CNAs that you see around the building. We also have engagement with life enrichment, nursing, and dining staff. So those interactions are not included in the ratio. So it's just really good to know how small those ratios are in actuality. We don't group together everyone, just strictly the care partners. So therefore, with a small staff to resident ratio, the care and clinical team work together to ensure that the residents receive their medication in a timely manner. So collaboration is key between clinical and care. So that's what we do in order for our residents to ensure that they receive their medication. And those are the 3 questions that were Kensington specific. But if you have any other questions, please feel free to reach out to us. We'd be happy to answer and provide any additional information. Dr. Faulkner, if you have anything else to finish us off.
No, it's just a reminder that we're all here for you, and go figure out what makes you happy and do it. And maybe tomorrow night, figure out your favorite thing in the world to eat and get it for dinner. It's that kind of a week. Otherwise, we thank you all for joining us tonight. I hope this was helpful. We all hope it was helpful. We're all here for you, I promise.